So joint diseases can be divided into several groups. In two big groups they can be divided in degenerative dystrophic diseases, or not, it can be divided in inflammatory and not inflammatory diseases. We will start with not inflammatory diseases, so-called degenerative dystrophic diseases of the joints. This division to two groups, inflammatory and non-inflammatory, is mostly based on the reason why the joint is suffering, the primary reason. In inflammatory diseases, the main pathogenetic factor is inflammation of the joints, tissues, and in the other groups, non-inflammatory, we also can see the inflammation, but in this group the inflammation of tissues are secondary, always secondary to the other reasons. Today we will be talking about degenerative dystrophic diseases such as osteoarthritis, and the second part, if we will have enough time, we will be talking about rheumatoid arthritis. I think both of these diseases are not new for you. You were studying them during previous classes and you know what is it and how they are looking like. So today we will focus our attention mostly on orthopedical treatment of these diseases. What can we do, like orthopedicians and surgeons? So first of all, previously we were talking about bones. Today we will be talking mostly about cartilage. So the difference between bones and cartilage, I think you understand, and you know how the cartilage and how the bone are looking like and where are they situated. The cartilage are placed in joints, and they are covering the joint ends of the bone. So cartilage is soft tissue and it consists of water, mostly of water. Compared to bones, it is consists 3 times more water than the bones, and organic components such as cells and matrix. According to clinical rentgenological classification, which is established in Ukraine, we divide 3 big groups of degenerative dystrophic changes in joints. It's deformative arthrosis, aseptic necrosis, and cystic alteration or cyst formation. There are 3 groups which are different, but at the same time they are closely connected one with another. When we are talking about these groups, we mention the primary focus of changes. In the case of deformative arthrosis, the primary focus is change in the cartilage and the subchondral bone. But during the development of deformative arthrosis, the aseptic necrosis of some locuses of the joint, and finally the cystic alteration of subchondral bones will be accompanied this problem. On the other hand, when we are talking about aseptic necrosis, it will be leading to development of cystic alteration and deformative arthrosis as well. So all these problems, all these 3 diseases are different, but at the same time they are combined in one patient during the whole history of the diseases. So all of them are leading one to the other, and the only difference is from where the changes began. Osteoarthrosis or osteoarthritis, or also you can meet the term deformative arthrosis, deformative arthritis, is the synonyms. All these terms are synonyms. In world literature, it is mostly used the term osteoarthrosis or osteoarthritis. In Ukraine, it is still very popular deformative arthrosis, but it is synonyms and they mean the same disease. The osteoarthritis is coming. The term is coming from Greek terms and means means bone, osteo, and arthros, joint, and the suffix itis, which mean inflammation, or osis, which mean a chronic process. So osteoarthritis is the problem, is the disease which is affecting the joint, the cartilage, and subchondral bones, osteo bones, arthros, joint. According to American College of Rheumatology, osteoarthritis is a heterogenic group of diseases which have very similar signs and symptoms, and which is associated with defective integrity of the cartilage. What we mean by heterogeneous group of conditions? In fact, for today's means, osteoarthrosis is not the one problem. Osteoarthrosis, osteoarthritis, is a group of diseases which have different phenotypes, and all these 6 phenotypes, and all these phenotypes are caused by different reasons. They have some specialities in pathogenesis, in development of this pathological process, and in most cases they need different treatment. So it is not the only diseases, so it's a group of diseases which are very similar one to each other. Osteoarthrosis is very widespread problem of joints and can affect each joint of patient's body. In most cases, the patients have compliance for knee joints, shoulders, hand and hip joints. Osteoarthritis of the spine has special term which is called osteochondrosis, and it is not the topic we will be talking today, because it is quite in another disease, have quite another symptoms and treatment than, for example, knee osteoarthrosis or osteoarthrosis of the hip or elbow. So what is cartilage and what is the cartilage is serving for? Why we are talking about problem with cartilage? So what is it? It is a specialized form of tissue that can bear stresses without permanent distortion. So it is very important function of the cartilage. So if after some weight bearing or stress or something like that, a bony tissue can't restore their shape very fast, so cartilage can do this. Cartilage consists of cells and extracellular matrix. Extracellular matrix is very interesting component of the cartilage, because it consists of fibers, collagen, and the structure of this extracellular matrix is very unique, not for each person, but for each joint of the person as well. So this three-dimension architecture of matrix of these fibers is developed through all the life of people who were living, and it is changed during the life according to the movements in the different types of joints. The cartilage is a vascular tissue, so that means that you will see no capillary network in healthy cartilage. You can find only few vessels which are transit. That means that vascularization of the cartilage is not the way how the cartilage receives their nutrition. So vascularized cartilage, when you see a lot of capillaries, means not good. It means the cartilage is suffering. There are three types of cartilage in our body. It's hyalinic cartilage. It's the cartilage which is covering joint surfaces, elastic cartilage, and fibrocartilage. We will be talking about hyaline cartilage today, because osteoarthrosis is about this type of cartilage. Elastic cartilage, for example, in the ear, in the nose, it is not suffering for this problem. As well as the fibrocartilage, which is placed in the intervertebral disc, because of their function and their structure, is not suffering for this problem as well. So hyaline cartilage is mostly spread type of cartilage in our body. It consists of cells such as chondrocytes and chondroblasts, and extracellular matrix, which is mostly presented of collagen, the second type of collagen. As you remember, there are a lot of different types of collagen, but in hyalinic or in the joint cartilage, the type 2 collagen is prevalent. The interesting thing of collagen, there are a lot of interesting things about collagen, but what you should remember that the half-life of the second type of collagen in people is about 100 years. So it is very important to understand and to remember when we will be talking about the treatment of the degenerative dystrophic diseases. So, as well is interesting structure as hyaluronic acid, which is also fulfilling the matrix of the cartilage. Besides, there are a lot of proteoglycans, such as glycosaminoglycans and chondroitin sulfate. So, very interesting structures which are also widely used in the treatment of osteoarthrosis cartilage. So all these three components will be mentioned during when we will be talking about treatment. You should remember these three components. Proteoglycans have very interesting structure. As you see here, it is long fibers with proteins, coproteins, and glycosaminoglycans, which are attached to this hyaluronic acid molecule, long core, long fiber. So it is looking like a pine, yes, it's just a New Year tree branch with these needles. So it is very interesting structure because for several moments. First of all, these long fibers has so-called hydrophilic tails, active components of the molecule, which can absorb and hold, which can hold the molecules of the water. They can hold a great volume of water, and these properties are helping this osmotic activity is the reason why the healthy cartilage can enable their so high pressures and forces. It is because of that. The interesting thing that when the patient is growing and matured, so these hydrophilic tails are shortening. So they become shorter and shorter, and that is why the properties, the turgor of the cartilage, with aging of patients, the cartilage is losing the properties to bear great forces, and that is why the patients become more shorter when they are old. So the height of the thickness of the cartilage is decreasing. So remember about these properties of proteoglycans as well, because it is very important when we will be talking about treatment. Shortening the hydrophilic tails in aged people. So these glucosaminoglycans are synthesized in that way. So they have shorter and shorter and shorter glucosaminoglycan tails. So they have less and less and less properties to hold the enough amount of water to provide the elastic properties of the cartilage. As I told you, with aging, chondrocytes seems less efficient in renewing the matrix. They are losing their properties in synthesis of proteoglycans, and very small changes are seen with collagen. So collagen is very long-lasting structure. So how the cartilage receives their nutrition? As we told, they have no blood network. As they have their own network, capillary network. So how they receive the nutrition? Because most of our organs receive nutrition components from the blood. If they don't have capillaries, they don't have they will not receive enough nutrition. So the cartilage receives their nutrition in two ways. First of all, it is subchondral capillary loops in subchondral bone layer. This way of nutrition is widespread in young people and children. They have very good developed capillary network in subchondral layers. These capillary networks also admit the nutrition to the growth plates, growth zones of the bones, and as well to the surface of the cartilage. And the second way is so-called the mechanism of the sponge. During the aging, the subchondral bone began more stiff, and the sclerotic changes of subchondral bone are accompanied. So it is harder and harder to receive enough nutrition from the subchondral capillaries. And in this way, the sponge nutrition is prevalent. As we told, the cartilage have very good developed elastic properties. The same as the sponge. When you wash a dish and you take a sponge in the hand, you can compress it easily, then put it in the water and release the pressure. So you will see how the sponge will absorb the water inside. When you put the sponge from the water, you can compress it easily as well, and you see how the water is easily depressed from the sponge. The same situation is with the cartilage. During our motion, during our the activity, the cartilage is repeatedly pressed and depressed, and this helps the nutrition components from synovial fluid to admit to the cartilage. Synovial fluid is the fluid which is synthesized by synovial membrane. Synovial membrane is a very thin layer of cells, synoviocytes, which is covering the inner part of the joint capsula. Normally it is a layer of cells. In some pathological condition, this layer of cells began to grow. We called it proliferation of synovial membrane. And it is very important that the capsula of the joint have good blood supply. This allows synoviocytes to synthesize enough nutrition components into the synovial fluid, which is covering all the surface of the cartilage and helps us in movement, of course, and as nutrition of the cartilage as well. So sometimes in the patients who have problems with their joints, sometimes patients will come to you with complaints that they have had a strange phenomena in the joint, so cracking in the joint. Sometimes it is they believe that they have not enough synovial fluid, and that's why they do hear these cracking sounds inside the joint. It's not the truth. This sound phenomena are caused by different reasons, not because they have not enough fluid, but also you should remember about this synovial fluid, which is playing a great role in nutrition of the cartilage. So who is on the risk to get osteoarthritis, and who is the typical patient of orthopedical department with this problem? Middle-aged and aged patients are mostly common to have such problems. It's after 40 years old and older. Very rare it is patients who are young. In most cases, young patients are suffering for post-traumatic osteoarthritis after different fractures, interarticular fractures, different traumas of the joints, and so on. Women have a greater risk to receive osteoarthritis than men, and there are some risk factors which are helping this disease to develop faster and get patients to the risk groups. First of all, you should remember that osteoarthritis can be primary. In this case, we don't know why it is happening. The risk factor, the causal factor, it can't be dimensioned. And secondary. Secondary, it is the situation when we have etiological factor or risk factors which were leading to this problem. According to Ukrainian classification, which is established by our Ukrainian Association of Rheumatologists, we can divide osteoarthrosis in different classes. It is important because now we will turn to risk factors and you will understand how different risk factors are leading to different types of osteoarthrosis. So, clinical forms, it can be monoarthritis, when it is affected one joint, oligoarthritis, few joints are affected, and polyosteoarthritis, when there are more than 3 or 4 joints. Osteoarthritis can be localized by the type of joint. For example, osteoarthritis of the knee or of the joints, of the bones joints, of the bones knees, of the bone hips, and so on. It can be accompanied by synovitis or not, and of course it must be evaluated by Kellgren and Lawrence classification by grades. And now about risk factors which can lead to this problem. For example, mechanical osteoarthritis in the patients who are working hard jobs, for example. In most cases it is mono or oligoarthritis. For example, they are bearing high weights on the shops or something like that. Excess weight, obesity, is a risk factor for osteoarthritis. In this case, we will be talking mostly about oligo or polyosteoarthrosis, because not only joints of lower extremities are suffering from the excess weight, but also obesity is leading to systemic problems with nutrition, systemic problems with endocrine system, and so on. So in this case, in most cases, it will be oligo and polyosteoarthrosis. Of course, the joints of lower extremities, such as hips and knees, ankles, will be manifested at the beginning of the disease, but still the changes are seen in all the joints. Dysplasia of the hips, as we talked last lecture, dysplasia of the hips, untreated dysplasia, is leading to the development of early osteoarthrosis of the hips. It is situation or for not only dysplasia as well as dislocation of the hips, congenital dislocation of the hips. So it can this is the situation which can lead to development of osteoarthrosis of the hips in young patients, about 20 years old and older. Different types of trauma, fracture, interarticular fractures, periarticular fractures, the trauma of ligaments, instability of the joints because of trauma of the capsula or tendons. All this is leading to development of osteoarthritis as well. In most cases it is oligoarthritis, because in most cases it is rarely when the patient has, for example, the fracture of both knees or the luxation of both hips at once. So in most cases it's monoarthritis, and it is secondary osteoarthritis, and so on and so on and so on. Some infection disease, inflammatory diseases of joints, they are leading to the development of secondary osteoarthritis. So in all these cases we can find a reason which was leading to the development of the pathological process. If you have no reason, it is idiopathic. So idiopathic arthritis with no reasons. If you have reason, if you have risk factor in anamnesis, if you have some traumas or something like that, it is secondary osteoarthritis. What are the clinical features of osteoarthritis with what patients will come to you? First of all, the main complaint is pain. Pain is the main symptom and the most early symptom of any problem with the joint. Osteoarthritis, rheumatoid arthritis, cyst formation, and so on and so on and so on. Pain is the main reason why the patients will come to you as fast as they can. In the case of osteoarthritis, we have a special types of pain. Now, first of all, pain can be located in the place which of the joint which is affected, and sometimes we have irradiation pain. The very specific symptom of osteoarthritis is so-called starting pain. It is a pain which appears in patients at the beginning of the movement and very quickly disappeared after few movements, few seconds after the patient starts their movement. So it is a very specific symptom for osteoarthritis. This starting pain is the result of problems with elasticity of the cartilage, with turgor of the cartilage, and is caused by increased pressure. So in healthy people, cartilage is very elastic, and that's why this pressure which is growing during the rest is decreased at the same moment of the beginning of the movement. If the cartilage is changed, we have changing, so it is not so elastic, and this pressure can't be decreased so fast. So that is the mechanism of starting pain. The patient will tell you that they feel pain after they were sitting for a long time or were riding a car for a long time, so they feel a pain during fast steps, fast movements. So then the pain is disappearing and they feel normal. The pain can increase after some physical activity as well. So patients who are suffering from osteoarthritis will also have complaints that they can't walk for a long time, they can't run, they can't walk for a long time, they need short rest. Sometimes in severe forms this periods of physical activity is shortening and shortening and shortening. So the patient will tell you that I am walking 100 meters, then I must sit and rest for a few minutes, then I can walk another 100 meters, then I need to rest again because they feel severe pain in their joints. Decreasing movement of joints, decreasing limitation of motion. It is also very popular symptom, but in most cases it is the late symptom, the symptom of late osteoarthritis, well developed of osteoarthritis. It is caused by mostly by severe destruction of interarticular structures, joint capsula, formation of scars, and so on. Instability of the joints, then patient will tell you that I feel no sure of my joint. For example, I want to run, or I am walking downstairs and I must think how to put my leg when I am climbing downstairs, upstairs, or going downstairs. So they can't walk easily as you can, so they must think how to put their leg, they must think how do they do the next step, and so on and so on. Morning stiffness, they feel not good at the morning as well, but this stiffness is very short, less than 30 minutes. If the stiffness is lasting more than 30 minutes, it means that we have with a big chance inflammatory problem, not degenerative dystrophy. Swelling can be caused by different reasons. Swelling of the joint. First of all, it can be caused by edema of soft tissues which are surrounding the joint, the edema of capsular ligaments. And the other reason, it can be caused by effusion in the joint, synovitis, extra fluid. Synovial membrane began to produce more synovial fluid to help the patient to perform the movements in the damaged joint. Crepitation of the joint. Sometimes you will hear this sound phenomena which we were talking. Patients will show you their possibilities of crepitation. When they move, you see these sounds, you can hear the sounds. Joint deformation as well, it is late symptom of the osteoarthritis, because it takes a few years to receive the deformation of the limb. Except you must remember that there can be congenital deformation of the limbs and post-traumatic deformations of the limbs, which can lead to development of osteoarthritis in patients. So you must determine, is it a primary deformation which was the cause of the osteoarthritis, or it is deformation which is the consequence of osteoarthritis, is a result of problem. So be attentive and take anamnesis correctly. So deformation is not only the result of osteoarthritis, it can be the reason of development of osteoarthritis. It is very important because you must understand what are you treating and what must you focus your attention on: correction of the axis or treating osteoarthritis consequences. Unfortunately, or maybe fortunately, there are no specific laboratory tests which can show us the development of osteoarthritis. Most laboratory tests which are used in the osteoarthritis diagnostic are not specific. They mostly show us the general activity of the process, but not the reason. And in most cases they have only scientific interest. We can evaluate the activity of catabolic or metabolical changes in the joints, but it has no very few practical value. So mostly it is for science to understand how different remedies are acting. In the patients in patients with osteoarthritis, we can see general types of inflammatory changes, such as erythrocyte sedimentation rate, which is increasing, positive C-reactive protein, which is increasing as well. But nothing special at all. Nothing special will show you that this is osteoarthritis. So if we have no laboratory test, how can we put the diagnosis of osteoarthritis? The diagnosis of osteoarthritis is put only according to clinical and rentgenological changes. Clinical symptoms and rentgenological changes which are seen on X-ray. There are a lot of different types of classification for osteoarthrosis. For different joints there are different classifications, but one of the most popular is Kellgren-Lawrence classification, which can be applied to any type of the joint, to all joints. If you are reading the papers or books and you see the classifications, for example, X-ray picture of osteoarthrosis third grade, it's Kellgren-Lawrence for sure classification. It's universal classification which is used all over the world. According to this classification, we are dividing the changes into several degrees. So 0 degrees healthy joint. It is so-called symptomatically osteoarthritis. So only the patient have only few complaints for their joints. For example, pain after severe activity of the joints or something like that. So it's considered to be healthy patient. The first stage is doubtful joint space narrowing and possible osteophytic lipping. So what is doubtful? It means that you are not sure is this space is good or not, joint space. What is joint space at all on X-ray? As we told at the beginning, the cartilage is a soft tissue. We can't see the cartilage on X-ray. It looks like an empty space between two bones. But this empty space is not empty for sure. This empty space on X-ray is fulfilled by a cartilage. So this space, joint space, is the thickness of cartilage. And when you are not sure, so you are looking, it is looking like good, but you have some doubt. So as in the case of fractures, if you are not sure, just perform the symmetrical joint and compare the right side and the left side of the symmetrical joints. You will see the difference. If you see the difference, in most cases it is the early symptom of osteoarthritis. The second stage is defined osteophytes. It's a small bony formations which appeared at the margin between the cartilage and the bone. Where the cartilage is attaching the bones, the small osteophytes are appearing. They can be easily determined on X-ray. And of course, in the second stage, the joint space is losing their thickness. And you will see this difference very correctly. The third and the fourth stage of osteoarthritis are easily to determine using X-ray because joint space narrowing is severe. We receive the first signs of sclerosis of the subchondral bone, deformation of the axis, severe osteophytes, and so on and so on, with definite changes which are in the joint. Just like here, you see the fourth stage of osteoarthritis. Just look, the third and the fourth stage, it's for sure damaged joint. So the most problematic is first two joints, which considered to be first and the second stage of osteoarthritis. On the first stage, you see the joint space is looking like good, but it's not so good as it is possible. After you will watch these X-rays daily, you will see the difference between the normal and abnormal joint space. And you see the first signs of osteosclerosis on the second stage, such white lines. On the third stage it is completely easy to be seen here and here. On the second stage they are appearing only. So it is the signs of subchondral osteosclerosis. So this layer of the bone, which is covered by the cartilage, has sclerotic change, as you see here. And here you can see so-called osteophytes, small bony formations here, and their deformation of the axis as in the fourth stage of osteoarthrosis. You see the joint space is completely lost, and you see such a varus deformation of the tibial bone with decreasing high of the medial plateau of the tibia, just like here, but it is here on the fourth stage it is more severe. And osteoporosis on the second stage. You see the first stage, the bone is looking like very good, and on the second stage and it will appear the first signs of local osteoporotic changes in the epiphyses of the bones which are forming the joint. On the third stage you see the severe osteoporotic changes here compared to the second stage. The same situation is with hip joint as well. The first stage it is looking like new, but still it is not so beautiful as healthy one. And the fourth stage you see the completely loose of the femoral joint. And pay attention, for example, for this second and the third pictures. Here and here we have formation of the cysts. That's what I was talking at the beginning. We have osteoarthrosis of the hip joints, which is accompanied by formation of the cysts here and here. A big cyst is formed in the subchondral layers of the bone. As well, here it is osteophytes, typical osteophytes on the roof of the femoral joint. And in the last stage you see a lot of cysts which are formed not only in the femoral head, but as you pay attention, the cysts are forming in the acetabulum roof, just like here and here. So two big cysts which are forming here. So the fourth stage as well, subchondral sclerosis. This white lines are showing us the sclerotic changes and osteoporotic changes on the second and third stages. In the knee joints, that's how the cartilage, healthy cartilage, is looking like. You see healthy cartilage of the femoral bone, of the tibial plateau, and it is a margin of the menisc. This is synovial fluid, how it is looking like. You see it is looking clear, yes, and all the cartilage is beautiful white surface, has its normal cartilage, how it is looking like. And that's how the cartilage with osteoarthritis, how it is looking like. It's macroscopically what can you see during arthroscopy, for example. So you see the defects of the cartilage. The cartilage have such is not so soft, it is not so beautiful. You see this small just like needles on the surface of the cartilage. And the menisc, you see, it is completely loosed, it is destroyed, it is not so beautiful as well. And the synovial fluid, you see, it is not clear, so a lot of small pieces of the cartilage, of the synovial membrane, everything is floating inside the joint. So that is the difference between healthy and the cartilage and the joint which is affected by the process. Ultrasound is used to look inside the joint as well. On the ultrasound you can see, for example, it is ultrasound of the knee joint. You can see the prolabation of meniscs. You can see the thickness of the cartilage, just like here and here. It is two bones and it is the thickness of the cartilage, but mostly we don't use sonography, or rarely use it, because in most cases X-ray is enough. Uh, X-ray is a gold standard. In most cases, X-ray is gold standard in traumatology and orthopedic. Also, in the case of osteoarthrosis, X-ray is a gold standard as well. So you can see everything you need to put the correct diagnosis and the stage of the osteoarthrosis using only X-ray. And how it is looking like here, it is the severe form of osteoarthrosis of the knee. You see the problem with axis of the knee, of the limb, so varus deformation of the knee joints. It is how it is looking on the X-ray and how it is looking in patient. Here you see how the joint is deformed. Arthroscopy is used as a treatment method mostly, but sometimes it is used as diagnostical method when we see no changes on the X-ray, or we don't see the changes in MRI, but patients have compliance which show us that osteoarthrosis is developed, and so then we can use arthroscopic techniques. For today we have not only classical, so-called classical arthroscopy techniques, but also we can use so-called nano arthroscopic devices, which allows us to perform diagnostic arthroscopy of all joints, not only knee, using only local anesthesia, and there is no need to put patient in the hospital for this procedure. It is very thin devices, which is looking just like a needle. You can penetrate the skin and soft tissues, put it inside the joint and see all changes which are happening in the joint. MRI and computer tomography are used in patients which are undergoing a surgery of joints for treatment of osteoarthrosis. For example, post-traumatic osteoarthrosis with cartilage defects, when we want to restore the cartilage, so we can use MRI or computer tomography, but it is not a routine method for diagnosis of osteoarthrosis. The last stage of osteoarthrosis, the most severe, as you see, we can see here loose bodies, the fragments of the cartilage which are floating in the capsula of the hip. Sink. So there are a lot of different treatment protocols for osteoarthrosis. There are a lot of organizations which are acting with treatment of osteoarthrosis. The most popular and the most widespread organization are depicted in the slide. It's American College of Rheumatologists, European Anti-Rheumatic League, American Academy of Orthopedic and Surgeons, and so on and so on. From time to time they are upgrading their protocols of treatment of osteoarthrosis of different localization according to the last news, to the last achievements of medicine, to receive a better treatment result of osteoarthrosis. As you understand, the osteoarthrosis is a very widespread problem. A lot of people are suffering from pain in the joints, so it is very popular stream of treatment, and there are a lot of different remedies which are not enough good enough. They don't have enough efficacy in treatment, but they are still prescribed by different specialists. So what are the treatment purpose, the aim of the treatment of osteoarthrosis? As you understand, the osteoarthrosis is a chronic problem which can't be treated for all. So we can only slow down the progression of osteoarthritis, and we can only fix fix the stage of osteoarthritis, but it is very poor chance to get to make joints better. Besides, we should reduce the pain of patient, because the pain, as we told, is the main compliance which will lead the patients to the hospital, to you. They are feeling bad, they feel pain in their joints, so we must do something to help them. And of course, we must to increase the functional activity. We must preserve the joint mobility, the range of motion of the joints, because the patient will be not very satisfied if the joints will be not acting in the correct way. Every time the treatment of osteoarthritis begin with non-pharmacological treatment. About half of all patients will receive a good result of treatment without pharmacological moment. So first of all, you must find the reason of the osteoarthritis, why this problem has begun. If the patient have obesity, it is very good idea to reduce the weight of patient. If the patient will lose several kilograms, they will receive a good pain control and functional activity without any additional drugs or something like that. So a reduction of weight is very critical for patients with obesity and excess weight. The second and the most popular drugs which are used to treat the joint disease are non-steroidal anti-inflammatory drugs. It is the most popular drugs in the world which are sold in chemistry shops. So different types of non-steroids are used for treatment of osteoarthritis. There are no one special magic pill of non-steroids for the patients with different types of osteoarthritis. Then a lot of other medicines are used to increase the microcirculations of the joint region. Different gels with non-steroids, with warming effects or cooling effects are used. Steroids are widely used to treat the pain in osteoarthritis and synovitis which is developed during this condition. Intra-articular steroids are injected, and of course surgery, depending on the stage of the development, different type of surgeries are applied. Besides, you must start always with education of patient. You must explain them what to wait from the disease, because some patients are waiting a magic remedy for him. So after you perform the treatment course, the patient feel much more better, the symptoms are over, the pain is over, swelling is over, they feel just like nothing has happened, and they do nothing after that. So they turn back to their normal life, they are doing their normal physical activities, and after a few time they receive the regression of positive effects, and the pain is turning back. They feel swelling of the joint, and again the pain in the joint they are feeling again. So they come to you with unsatisfactory, because they were waiting another result. So always explain them that all treatment is temporary. Unfortunately, the joint will be not turned younger than it is, and some signs of osteoarthritis, some signs, some symptoms will be appearing from time to time, and the treatment must be not only symptomatically but also a prevention. From time to time they should to do some treatment methods to to prevent the reduction of osteoarthritis. And it is very important to explain them how they should modify their life, because in most cases during last several years, some 20-30 years, it is increasing amount of young patients who are not using enough physical activities. They are office workers and they don't have enough activity, so they are sitting all the day on the chairs in the offices, and they have overweightings. So this life must be modified, and these patients must receive enough activity for their joints, for their muscles, because the muscle tonus is very critical for receiving a good result. About 70% of good result of your treatment depends of muscle tonus, for example for the knee joint. That's why patients must have long walks on the fresh air, to do regular physical activities in physical halls, to ride a bike, to swim in the swimming pool, to run or something like that. So if they will restore a good muscle tonus, they will receive a good result in treatment of osteoarthritis. If they will be lying on the bed for 24 hours and taking pills, they will receive nothing. Non-steroids, very interesting topic. I don't know if you were discussing it during your pharmacological courses, but you should remember that non-steroids have also their own classification, and all non-steroids are divided into pharmacological groups. And one of the most interesting thing about non-steroids, which is always forgotten by doctors and which is poorly knew by patients, that each person have their own sensitivity for different groups of non-steroids. What does it mean? It means that when you are prescribing only one non-steroid for all patients, some group of patients will not receive a good result of taking it, because it's physiologically there is non-sensitivity for this drug. So that's why it is important to remember several groups of these drugs, and if you don't receive the good clinical effect of prescription after prescription of one of them, you should change the group, but not the pharmacological name of the drug. For example, such very popular drug as diclofenac natrium has several pharmacological names, such for example diclobrew, dicloberyl, diclo, and so on and so on, but still the group is the same and the remedy is the same. It is the same diclofenac natrium. So if you will not receive a result from prescription of diclofen, you will not receive the good result after prescription of dicloberyl, so because you are changing nothing. So if you don't receive this good result, so change for eteracoxib or xefocam, so you must change the pharmacological groups. That's why it is very important to know these pharmacological groups and most widely used remedies between them. So don't receive the result, change the group. If you will not receive the result after this changing, change the other group. Sometimes you should test three different groups of non-steroids to receive a good result. The second specific of these drugs is the combination of these drugs. Sometimes, if the doctor or patient is not receiving enough clinical significant effect of one of these drugs, he is prescribing to take the combination of two different groups of non-steroids, for example, ketoprofen and diclofenac. So sometimes it works, but in most cases it works because we are changing the group, but not we are using the combination of steroids. And this moment has very bad side effect. The combination of two non-steroids in one patient is increasing the risk of complication for 2 times. The combination of 3 non-steroids is increasing the risk of complications for 4 times. So the main complication which we remember about non-steroids is gastrointestinal complications. Yes, bleeding of gastrointestinal tract, development of ulcers of the stomach. But as well we are forgetting about possible complication of ulcers not only in the stomach but also in the duodenum. And how to avoid it? We are using selective non-steroids. As you remember, there are 2 groups of non-steroids: selective cyclooxygenase 1 and non-selective. Non-selective inhibitors of cyclooxygenase are associated with higher risk of gastrointestinal complication in patients. That's why some doctors are prescribing only selective inhibitors of cyclooxygenase because they believe that it is a lower risk of complications. Yes, it's true, but only partially. That is the next point you should remember, that selective inhibitors of cyclooxygenase really have lower risk factors for development of gastrointestinal diseases, but they have a very high risk for development complications from the cardiovascular diseases, higher blood pressure and heart strokes. So don't forget about this when you are prescribing the remedy. So pay attention not only for complications from gastrointestinal but also for patients with hypertension. So maybe it is better to prescribe non-selective cyclooxygenase drug with combination of blockaders of proton pump or some omeprazole, for example, to avoid this gastrointestinal complications, than to prescribe the only cyclooxygenase selective remedy. So don't forget about these possible complications, and don't try to prescribe the combination of non-steroids in one patient. One of the most popular during last years is eterocoxib. It's remedy which is highly selective cyclooxygenase, and it is this eterocoxib. It has the other one very interesting story. So this eterocoxib drug was firstly introduced to the medicine, to the as a remedy against 3 diseases: rheumatoid arthritis, ankylosing spondylitis and gout. So there were only 3 prescriptions when we can use this remedy. And after a few years clinical trials have finished, and this ataraxib shows a good result in treatment of osteoarthritis. But the fact is that during these few years, until we received this extra prescription, a lot of doctors who were using taraxib in patients with rheumatoid arthritis saw their very powerful anti-inflammatory effect, and they were trying to prescribe taraxib in other different diseases, for example in osteochondrosis, in the neurology, and so on and so on, and they found no effect, they received no effect. So they decided that taraxib is not sufficient, and a lot of patients were taking this taraxib for headache, for the lower back pain, for traumas. They don't feel enough efficiencies, and they told that this is bad drug. So that's why you should remember that each remedy has its indications. So don't try to change indications in remedies. Only after clinical trials we can change the indications, and we can use the drugs, because you will lost the time, and patients will lost the time as well, and lost their health and money taking the drugs which are not efficient for their problem. In some countries, in Western countries, cannabinoids are widely used for patients with severe osteoarthritis, with chronic pains. It allows to receive a good anti-inflammatory analgesic effect with using topically cannabinoids as different ointments, and systemic by just like a drug. So it helps them to decrease the pain, and sometimes it is enough for them, and helps them to avoid very expensive and difficult surgery. So the recommendation is very strong for cannabinoids according to the international clinical trials. They show good effect in pain relief of osteoarthritis. Homeopathy and different other magic pills are very popular in Ukraine, in different TV programs, in radio, in different newspapers. There are a lot of drugs which are selling to renew the cartilage. They promise the relief of pain, and that the cartilage will be just like new. But there is no evidence that they are really helpful for this problem, not only for osteoarthritis but for other problems as well. So don't try to use it. Besides, sometimes you can hear such talks that homeopathy is safe. No, unfortunately homeopathy is not so safe as they promise for us, because I have several patients which were undergoing treatment in by homeopathical injections, which was leading to severe destruction of the joints, severe destruction and fast destruction for few months. Patients who were walking and who decided to help their joints, as they told, it is often the phrase of patients, I want to help my joints. So they receive severe inability, and they undergo serious surgeries, joint replacement, because there was nothing to save after this homeopathic procedures and homeopathic injections. So don't believe and don't use this. Don't use it at all. One of the most popular drugs which is used for treatment of osteoarthritis is so-called slowly acted drugs, or also they are known as chondroprotectors. And they consist of chondroitin sulfate and glycosaminoglycan. That's the elements of the matrix of the cartilage, you remember. So it is believed that these remedies are penetrating from the stomach to the blood, then from the blood to the synovial fluid. They will increase the quality of the synovial fluid. It will lead to better metabolism of the cartilage, and it will lead to renewal of the cartilage, and so on and so on and so on. So unfortunately for up today, we have very poor evidence-based, not only we, or all the orthopedical society has only very poor evidence of using of these drugs for treatment of osteoarthritis. Of course, after a long period of taking these drugs, patients feel much more better, but in most cases it is because they are property to block the anti-inflammatory cytokines, interleukin-1 for example, but not because they are renewing the cartilage. So the effect is only anti-inflammatory. And if you look, for example, there are two big, very world popular drugs, Structum and Dona, and there are a lot of different other drugs which consist the same remedy, chondroitin sulfate and glucosaminoglycan. A lot of drugs in the drug shops, they are not very cheap, or in most cases they are very expensive. They consist different herbs, they can consist different herbs as well, and all they promise the renewing of the cartilage. But if you will read the complex which is included in these drugs, for sure you will find some herbal elements or chemical elements which have anti-inflammatory effect. During last years it is very popular to include in this chondroprotector such component as avocado, avocado soaps, avocado oils. They are acting just like anti-inflammatory. The same property has curcumin, for example, from curcuma as well. When you are reading the complex, you will see that there is curcuma or avocado or soya. After the patients start to receive these remedies, of course they feel much more better because it is anti-inflammatory only effect, but it is nothing about renewing of the cartilage. Hyaluronic acid, very popular injection, which is widely used for treatment of osteoarthritis. The problem is that there is, again, it is very poor evidence-based for using of osteoarthritis as a treatment method for treatment of osteoarthritis, and there is a completely science about this hyaluronic acid, different molecular weight, different formulas, different additions to the hyaluronic acid, different magazines, different societies which are popularized this method of treatment. But unfortunately, hyaluronic acid has only mechanical function in the joint, which is injected, only mechanical function, just like an oil in the engine. When you inject it in the joint, it is lubricated the surface of the cartilage, and patients feel a little bit better after these injections, just like a lubrication. As well as chondroprotectors, this remedy is not very cheap. They are expensive enough, and in most cases this procedure is recommended to be repeated after a few months, after a few weeks, depending on the components which are included in the syringe. And the fact is that this hyaluronic acid is eliminated from the joints for after several weeks, after 2 months after injection. You will see no signs of this injected remedy. And but when you read the prescription of the pharmacological companies, you will find that injection of hyaluronic acid provide excellent effect from 6 to 12 months. So how they can provide this effect for 6 or 12 months if they are eliminated after 1 month, it is a great secret for most doctors. Steroids are widely used for treatment of osteoarthritis, and the problem of steroids is their efficiency. We will be talking about steroids not only on osteoarthritis but also on rheumatoid arthritis. They have very potential, very powerful anti-inflammatory drug, very powerful. They have a good result. They undergo all recommendation and clinical trials. No doubt that they really help the patients, but with steroids there are some problems, and the main problem, as I told you, is their efficiency. Except good clinical effect of anti-inflammatory and analgesic, steroids, when they are used not correctly, they can cause such complication as steroidal arthropathy, degenerate additional damage of the cartilage. So that's why they are it is not recommended to use steroidal injections more than once a 6 months. And as in the case of non-steroids, in the case of steroidal treatment, we have personal sensitivity for these remedies. If you will not receive the good clinical result after one injection, you are very poor to have the good result after the second injection. So it's individual non-sensitivity for steroids, so don't try to repeat it. Sometimes doctors are forgetting about this. They know that steroids are very powerful, and they inject, for example, a patient with steroid and they don't receive a good result. So what they are thinking about, that they think that they must repeat immediately the second injection. So in few days, after few days, they perform the second injection, they don't receive a good result. They perform the third and the fourth injection until they received such complications. So don't forget about this. Besides, the steroids have the other one feature. They are decreasing the inflammatory in the joint, but also they are decreasing the local immunity in the place of injection. That's why injections of steroids must be performed only in dressing rooms, in small operating rooms, but not in the corridors and not in the cabinets of doctors. So aseptic and antiseptic gloves, antiseptics, cover of the field where you injected must be used obliged. It's impossible, it's forbidden to perform intra-articular injections somewhere else, but not in the dressing rooms with sterile environment. Surgical methods. Surgical methods are very interesting, and they are depending of the stage of the osteoarthrosis. First of all, it is so-called small surgery, such as arthroscopy, when we perform the removement of damaged elements of the cartilage, damaged elements of the meniscus, ligaments, and so on. We can perform excision of osteophytes or for free bodies, chondroid bodies of the joints, to prevent the future damage of the joints, and so on and so on and so on. In the case of problems with the axis of the limb, we are using such called correctional osteotomies. Correctional osteotomies, which are to restore the anatomical position of the bones which forms a joint, to reduce the valgus or varus deformity of the limbs, and it helps patients to use their joints for several years more. But in severe cases, when the joint is completely damaged, when we have the fourth or the third degrees of the osteoarthrosis, the only method of treatment we can propose a patient is total arthroplasty or artificial joint. It is one of the most popular surgeries during last years. Patients feel much more better just after the surgery. They can walk the next day. They have enough range of motion in these joints for daily activity, and sometimes they can even return to big sports. They can ride a bike, drive a car, so they don't feel any problems with this artificial joint. So fast but not very cheap method of treatment of severe forms of osteoarthrosis. By the way, on this X-ray you can see the results of untreated dysplasia, hip dysplasia of the patient. You see the flattened acetabulum and the femoral head, which is not completely covered by the roof of the acetabulum. So young patients which undergoes hip replacement because of untreated dysplasia in childhood. The same situation, different types of arthroplasty for different types of damaging of the joint. And the same situation with the knee joint. You see, we can not only restore the axis of the limb with this arthroplasty, but also to perform a good clinical result and to increase the quality of life of patients. They can walk without crutches with such devices inside the joints. Very new and popular method of treatment is so-called regenerative medicine, using stem cells, different types of growth factors and stem cells, different types for treatment and renewing their damaged cartilage. First, they were described in the middle of the 20th century. They were derived, as you remember, from the thrombocytes, which have signal alpha granules, which are playing a great role in the regeneration of the cartilage as well. There are several lines of such treatment. First is so-called platelet-rich plasma or prolotherapy, when we use high concentrations of derived from the patient's blood platelets injected in the joint or around the joint. The second line is derived of platelet plasma, uncellular remedies where there is no cells but only these growth factors isolated. It is used, we should use laboratory techniques to perform this treatment. Then we can use different products which are containing stem cells. We can receive patient stem cells from fat or bone marrow. We can update the stem cells in laboratory or without cultivation. We can use it. There are special devices to receive enough quantity of stem cells from the fat and bone marrow without laboratory biotechnological cascades. And the last one is contemporary. It's very efficient treatment, but very expensive. It's using of different types of cytokines and genetic engineering drugs, which are produced in laboratories, but which show good result and good safety. In Ukraine, is the most popular is using of stem cells with proceeding or without proceeding in the laboratory. As here you can see, I don't know why the video is not playing, but you can see the result of treatment of patient which has such disease as aseptic avascular necrosis of the femoral head previous and after the treatment of stem cells. So you can see here the changes in the femoral head, just like margin of osteonecrosis. So in this case we perform a canal using a wire from the trochanter to this focus of osteonecrosis and implantation of stem cells. So, and after a year you see the femoral head is completely restored, and it helps the patient to avoid the joint replacement. So it is very fast procedure which can be performed outpatient, so they don't need to lie for a long time in the hospital. So when they come visit you at the morning, at evening they are going home without any complications. So that's about osteoarthrosis. Let's